Basic Needs India. So it's a work that I find both heart and mind meeting together, because at a personal level, as a young man, I experienced emotional growth experiences. So at this stage, I find it's an involvement that's very meaningful. Yeah, so I have about 15 slides, but I have to take it through fast. We are a resource group. We call ourselves in community mental health and development. By that, what I mean is we approach the issue as a development issue originally, not as a mental health or a medical problem. The origin of Basic Needs India's approach. We started in 2000. We were supported at that time through Basic Needs UK, but the program was implemented and tested out in India. BNI, that's Basic Needs India, is an independent trust. The trustees have background, they're senior development practitioners and disability practitioners. That is why we started from a development approach. It works with poor persons with mental illness, PWMI stands for that, in rural areas and Bangalore urban. Methodology was developed through consulting with persons with mental illness and their carers. So what that means is the methodology was a response to the felt needs of the stakeholders. It includes the person with mental illness, the carers, as well as local community, NGO, whatever. We recognize right at the beginning that we have a limitation. We are not a psychiatric or a medical group. So that aspect was left to make access to the government resources. I'm not going to explain this slide because when I prepared it, I was thinking that the deinstitutionalization needs to be justified. But the kind of discussions that have gone on, there is no need for me to explain them. I would like to say that the Lancet series that was touched upon talks about 4 best practices that have been documented in terms of results. As I understand it is the role of the primary stakeholders in the program, community-based services, collaborative models, meaning many sectors involved, not just medical, and use of new generation antipsychotic drugs. So many groups have tried this out and have shown that the results are much better. So I'm sorry to use the word model. People have criticized us to use the word model. I'll say it is an approach or a strategy, whatever. So by stakeholder, because it has come from the ground, it is the primary stakeholders and other related stakeholders. So it's a stakeholder approach. And as we listen to the stakeholders and their needs, it was multiple, various areas, including, individuals saying we want to get married, we want to be respected, or we want our children to have education. So it was various things. So as a response, we felt it could be clubbed under 4 general strategies. Access to healthcare, and healthcare of course here means not just medical, sustainable livelihoods, capacity building of the external environment. So the people around and the various institutions, evidence-based advocacy, management of program, that is to say, management of the partnership, because we work through partnership. One of the strengths, which I'll again state later, is that because it is through partnerships with, primarily with other NGOs, usually community-based disability programs, NGOs running that, but also health programs. So it could be integrated into those programs, and therefore it could be scaled up, because we ourselves are not doing it in each place. So rapid scaling up through NGO partnership. In over the 10 years of our work, the program is working in parts of 8 states. I use the word parts because in places where those NGOs are located and they're working, in parts of 45 districts, in partnership with NGOs, resource organizations and individuals, and roughly involvement about 17,000 affected people and their families. So I'm going to speak about each of those strategies or modules a little more in length. The identification and documentation. See, the work is done through integrating this module into the NGO's work. It's not done as a standalone program. The NGO is already having field staff who understand the community, who may even know the families themselves, because they're credible NGOs who have been working there for many years. So now they integrate identifying mentally ill persons whom they even might have known but did not know how to intervene with. So now identification and documentation. A case file is started. Rapport building with the families. Again, through the field workers. They are the pivot, but in the beginning, the NGO head has to be sensitized, the middle-level people have to be sensitized, and finally one reaches through the field workers, who are the persons whose skills have to be built up. Organization of referral. Initially, we have a partnership, Dr. Ramswamy also knows, we have a partnership in the southern states. Initially, of course, 10 years ago, there was no access even at the district level to healthcare. So temporarily, some private health camps had to be held. But very soon, at the district level at least, access to healthcare became possible. The organization of referral, follow-up visits and education. That is what the field worker does. Capacity building. What do we mean by that? One of the important steps of capacity building originally is the consultation. It's a public event with the persons, their family members, that is their primary caregivers, the NGOs who are involved, perhaps some community leaders. And this is an occasion where people express their needs. The different groups express their needs, and also they articulate their roles in meeting the needs. So it's not like, a particular group is powerless and needs to be dependent. Each segment, even persons with mental illness, they have some roles. Maybe initially it is taking the medicines regularly, or self-care, whatever. So those roles are spelled out in a public platform. And then when the field worker interacts at the family level, they are seen from a different angle, because they're not seen as somebody coming to give something. It is right from the beginning we see the need for promoting responsibility. Caregivers Forum, Ramswamy, you already mentioned Caregivers Forum. Very important intervention, because the best convincer is somebody who has gone through the experience and found an answer. So that is where people who are more older in the program, or caregivers older in the program, they show the way. Okay, there's a problem in the client taking medicines, how it can be done. Or if somebody is not regular, they can speak powerfully. And later on, the Caregivers Forum take responsibility for running the meetings, or for referring people various levels. So gradually, this responsibility gets taken over. Community awareness, yes. Capacity building involves awareness of the CBOs, the local grassroots government officials or whatever. Yeah. And we use various forms like street theatre. I think many of the things he mentioned. And others. Yeah, sometimes need-based we have tried out other interventions, especially very resistant families, individuals. We have found residential camps, 3-day camps, the individual, the family member, staff, and in that time also some breakthrough happens because there's a trust built. Sustainable livelihoods. Though we have tried various things, I must say that's an area that requires further effective work. Reintegration in previous occupation is the most preferred way in the rural program because into the family activity that can happen. More recently, in the last 2-3 years, national employment and other schemes, Mahatma Gandhi guarantee scheme. So we have a considerable number of persons who are integrated into that program or other government schemes. In the urban program, we have tried work therapy or a vocational training center. It's quite expensive though, but it gives the skills, the social skills and other skills and supported placements. The last item is the most difficult, support to entrepreneurship as a family unit. It's you're straight away working in the larger market. It's very difficult to sustain that. Fourth module we call research and advocacy. Research for us means gathering evidence on program effectiveness. At our level of work, that's what we call research. So this involves training the field workers to gather data, consolidation formats at different levels, appropriate documents for dissemination to various groups, including for advocacy at different levels. Sometimes it so happens that the district administration will listen only if the numbers are shown. We have had experience early in the program where the documents at the district level showed there were no clients, no patients. Then when we were able to show that 300 names have already registered, then the collector was able to bring in a psychiatrist, etc., etc. So yes, evidence-based advocacy works. If at the ground level some force is there. Engaging with government at different levels. Yeah, you've said that. Management of program or management of the partnership. This is the last module. Here, of course, we say it as a module, but identification and contracting with partners. It's a stage where you look for credible NGOs who would like to see it as part of their central thrust, not because some funds are available. So that's an important discerning, because then only it becomes integrated eventually. Integration programs, plans and budgets. This has to be an important thing, that it is integrated. Not if an NGO wants separate funding for worker, for various things, then it stops at the end when the funding fails.